Morning, everybody. My name is Susan McKenzie, and I'm the CEO of the Emergency Services Foundation. It's lovely to have you with us here today. I want to acknowledge the Bunurong people here where I am on the Mornington Peninsula. They've been custodians of the land here for many, many thousands of years, and pay respects to their elders, past and present, and anyone who is with us here today of Indigenous heritage. So today we're talking about trauma, and I'm sure many of you here will relate to that. If it does trigger anything for you, I encourage you to speak to or speak with whoever you relate to best. And that might be a professional person, or it might be just a colleague or somebody from an internal organisational service. So what we're speaking about today is accumulated trauma. And how this came about is that ESF has run some programs over the last year where we had retired police officers and retired paramedics. And I was sitting in the room with them when Shannon did this part of the training. And I'll never forget this person turning to me and saying, "Susan, why has nobody ever told me this before?" It was like the penny dropped for this person. And I thought, wow, we really need to get this information out more broadly. And, you know, for me too, not being a frontline person, when I was sitting in the room and we were down at Life Saving Victoria at the time, and I was looking out the window thinking about traumatic events that had happened in my life that are not related, well, some are, but not all related to emergency services. And it really started to make a whole lot of sense for me. So when we think about the general public, and the general public will experience, you know, it's anywhere between 1 or 3 traumatic events in their lifetime. But as we know, emergency services are exposed to this every day sometimes. And it's repeated and it's prolonged, and it has the potential to be traumatic just by virtue of the work that they do. Not to mention all the things that go on in the workplace as well as part of, as quite separate to that response. I tend to refer to it as crap in the backpack that we're carrying around with us. My technical terms, as always. We've got Shannon with us today. And Dr. Shannon Hood is a clinical counsellor and trainer who's been working with ESF for the last couple of years. But for the last 20 plus years, he's been working with emergency services. And he started off in South Australia, and he's now based in Victoria, thank goodness. And he works with people right around the country. He is somebody who really understands this work, because he is or was a former SES volunteer himself, and he is a current CFA volunteer as well as his clinical counsellor. Now, before I go on and ask Shannon to begin this presentation, and I'll share some slides, I see some people aren't muted, so I am going to mute. I'm going to ask you to mute yourselves. I'm not going to mute all because I don't want to mute Shannon, but I can see people there not muted. So if you wouldn't mind doing that, that'd be great. So Shannon, over to you. And I would suggest to people to ask their questions in the chat box, because we've got so many people on here, I won't be able to manage. And I will start sharing some slides, Shannon.
Great, thank you. Thank you for the introduction, Susan. And that's a helpful helpful introduction, and I guess the context for this presentation is that we all know that psychoeducation is really a helpful part of supporting people who are going through all sorts of experiences, including trauma. And so long ago, I started drawing on whiteboards and things, brain diagrams, to try and explain to people some of what might be going on for them. Over time, those brain diagrams became less and less technical and more conceptual. And so certainly when you see my picture of the brain diagram, and Susan, I'm not sure if we can go to a slide view rather than a...
Oh, yeah. Okay.
But You wouldn't want to be doing neurosurgery based on the brain diagram pictures that I'm going to be showing you here. But this is very much intended as a model. And Susan spoke of when she first encountered this, how it helped make sense. And I guess that's what I'm trying to do, is to help people make sense of what's going on. Someone once told me that models are not right or wrong. They are either helpful or unhelpful. So I think that's a thing to be keeping in mind as I describe what's going on. For some of you, this will feel very technical in terms of brain information. And for others of you for whom this is your expertise, you'll think this is a bit dumbed down. And so as long as I'm somewhere in the middle there, I think I'm probably at around about the right spot. So I just say that in terms of the context of the purpose of the model is to support people and individuals in understanding what might be going on for them in terms of their trauma experience, and then helping explain how we might approach some way of actually supporting them in the midst of this. So I'm going to begin by talking about how I understand trauma to work in the brain. So we'll lay that foundation, and then we'll talk about, well, what does that mean for cumulative trauma as a secondary thing? So, and I guess just the context of coming together is I like to talk about the idea of the trauma being an unfortunate coming together of two perfectly wonderful and natural brain functions. One is the function of intrigue, and the other is the function of threat alert. And so when those two things overlap, which they do on odd occasions, they kind of work against each other. And so we want to take two perfectly normal, healthy, wonderful functions of the brain and get the best out of them, because sometimes when those two things coexist, they can kind of work against each other. So that's the concept. And so what I'll do is I'll first explain what I mean by the concept of intrigue. Then I'll talk about what I mean by the concept of the threat response. And then I'll talk about how, when they come together, what does that maybe mean for people and how does that work? So let's start, and we'll see the first slide, and you'll see that these are not going to be detailed pictures of the brain, but more concepts and ideas. So the concept here is, let's talk to begin with about memory making in the brain. And so we know what we're trying to show there in this image. In the bottom left-hand corner, we can see that there's all sorts of stuff going on outside of the brain that our senses pick up. So you can see the 5 little pictures there are sight, touch, taste, smell, and auditory input. And so those things are flowing into the brain at 1,000,000 miles an hour. They are happening for us all of the time. We are all experiencing that a continuous flow of all 5 sensory inputs while we're conscious and awake. And those things come into the brain, and occasionally there'll be something of interest that gets tagged. And so, you know, I've listed and sent off to long-term memory. And so I've listed there might have been something that about your drive to work this morning, or about your breakfast that you had that you can remember. But not necessarily all of that will stay long term, but it will kind of get some bits will get sent off. But what we know is that the majority of experiences that we have happened to us don't get recorded as memories. They just go off into the ether, which is that little cloud of poof smoke, and we choose to we ignore them, or we just decide that we're not going to process those. And this is a wonderful part of our brain function, that if we were trying to consciously deal with the ongoing continuous stream of everything that our 5 senses are inputting, that would be very taxing. So we have this wonderful capacity to filter through the irrelevant, and some of what happens in terms of our experiences, we send off to memory. So that's an important thing to be thinking about. So that's memory making. If we go to the next slide, I'll introduce the concept of what I refer to as intrigue. So in this kind of context, we have these sensory inputs coming through, and there's part of our brain that will receive a sensory input. Can be something we've heard, something we've seen, something we've felt, whatever it might be, that is a little bit different for some reason, or it's captured our attention, and we need to make sense of it. We need to somehow process it. It's got us thinking, it's intrigued us is a good word. And so where most of that work done, that sense-making, meaning-making work, is off in the front part of the brain in the prefrontal cortex. This is our executive function, our decision-making, but it's also where we do lots of our intelligent work. And so what makes for an intriguing experience? And this is the first thing that I think is really important and valuable when we're talking about trauma, is that what will be intriguing to one person will not be very intriguing to another. And so the first thing for us to understand is that any critical incident or any event may have intrigue for one person, but might not be intriguing for the person standing right next to them experiencing that same event. And some of the things that lead towards intrigue you can see listed on the left-hand side there. So if the experience is confounding, and by that I mean if it doesn't add up to your way and assumption of life, the way you think life should work, then you will find it confounding. So this is actually often why we find magic shows so intriguing, because things happen and we go, that's not meant to happen that way. Our world tells us that's defying gravity, or something is going on there. And so I'm suddenly intrigued because it's confounding. It's not, but confounding can also tap into some of our pretty significant personal beliefs. Things like parents are not meant to bury their children. If we are living with that belief and something happens in our life and it's contrary to that, we will find that confounding. We might have a fundamental belief that says that good things happen to good people and bad things happen to bad people, and all of a sudden we have some experience that is different to that. And we go, oh, okay, I've got to now process that. I've got to make sense of that because that is different to the way I thought the universe functioned. So that's what we mean by confounding. Another thing that will make for an intriguing experience, and so this is just a grab bag, not all intriguing experiences meet all of these criteria, but you can see what we're getting at here. So it might be that the experience was unexpected, caught us a bit by surprise. We weren't kind of anticipating it. It might be particularly horrific, or it might be particularly beautiful. And so the thing about intrigue is that intrigue is not a good or a bad thing. It's actually just a function of trying to make sense of something. And so, you hear people who talk about horrific things that happen and they'll say, I'll never forget that. And, that's caught their intrigue. But then you hear of people who talk about the moment they laid eyes on their loved one. And I can still remember meeting my now wife for the first time and seeing her for the first time, and that caught my intrigue, but not in a bad way, in quite a beautiful way. And so these things will capture our intrigue if it's something particularly horrific or particularly beautiful. If it's morally wrong, if it defies our sense of good and bad, right and wrong, then that will intrigue us and we'll have to make sense of it. If it's something particularly novel or new, that will also increase the likelihood that it's intriguing to us. If it's something that's particularly visually stimulating for men in particular, or emotionally stimulating for women in particular, then that's likely to capture our intrigue. And then the other, I list there personal, but really this is close to home. If an event happens and somehow it's close to home, it impacts us personally, then it will be more likely to be intriguing than if it's happening to somebody else or a person at a distance. So the point we're trying to make here is that we have this constant feed of experience, of data that's flowing in, and based on the journey through life. And sometimes there will be an event that's happening there. You can see my little friend with his kind of finger on his lip there. There's an event that's happened underneath him that the brain has noticed and gone, that has caught my attention. It's intriguing. I'm going to send that off to the prefrontal cortex to make some sense of it. How do I make meaning and sense of this thing? And once I've been able to make some meaning and sense to it, you can see the prefrontal cortex is putting a little tag on it. It's made some meaning out of it, sends it back and flicks it off to long-term memory. Usually that happens without our intending to, because if we've spent a lot of time thinking about something, there's a very, very good chance we will remember it long-term. So that's sort of the process flow of intrigue. Really helpful, really valuable. It's the kind of thing that is why humans ask questions like, why is the sky blue? And could we put a person on the moon? And all of those things that drive our healthy inquiry and our learning as we go through life. So really positive, this intrigue factor. Let's look at another positive impact, and many of you will be familiar with this kind of response, the fight, flight, alarm response, a response to threat. And I think that's an important thing to think about. That threat can be a physical threat, and I'm doing a little bit of too much self-disclosure here in the context of a recorded webinar with so many people. But if you want to trigger my alarm response, you can see that on the bottom left-hand corner, if my sensory input picks up something that in any way resembles a snake, you are going to trigger my alarm response. And so that could be a little rustle in the leaves. I was just walking down to the shed a couple of days ago, and there was a little something in the leaves, and my heart skipped, and I had this exact alarm alert response. I had data input, that rustle in the leaves, hot day, etc., prompted me to think maybe it's a snake, and we can talk about negativity bias and all that kind of stuff. But essentially, I had this thought, and I literally jumped. I had that literal fight flight response. I wasn't willing to. I would definitely not do the fight response because I'm too scared of them. Someone's once said snakes are more scared of you than you are of them. I think that's crap. I don't think anything could be more scared of me than a snake, than I am of a snake. But I was very ready for the flight response. Anyway, we all know about that function, and that sends all sorts of signals down our spinal cord, and all sorts of hormones are released to get us ready to fight, flight, or freeze. I'm going to go down the sympathetic parasympathetic system. That's too complicated. I used to have that on the model, but I got rid of that. So essentially, there's this response that happens. And what we know is that when that happens, I say in here that the prefrontal cortex goes offline and the memory making goes offline. To be accurate, we know that the function is significantly diminished, whether or not it's totally offline, but either way, we know that those functions are significantly diminished during this fight, flight, fright response. Again, fantastic response. If there genuinely was a snake and I had to get out of there, short-term, wonderful response. And sometimes when I talk about this, I like to do a lot of four-wheel driving with my family, and I talk about this as sort of the four-wheel drive setting. You know, this is a great setting to lock the hubs, go into four-wheel drive, and it can get me out of. Sorry, I've just got some audio coming over. Anyway, can get me out of a tricky spot if I need to, but you don't want to drive all the time with your car in four-wheel drive because you will experience diff wind, and that is a bad thing. I think I just got muted and I'll unmute myself. Is that right? Beautiful. Thanks, Cliff, for the thumbs up. So anyway, point here being very helpful, very good, very useful response. And I don't think we need to say too much more about that. And the important thing after that alarm response is that there's a proactive all clear response. So I'm walking along, think that's a snake. No, it's not a snake. It was just a bird. Don't worry about it too much. So I sent, and I say there, the threat has passed. It's more scared of you. You're near first aid. Don't worry, if you got bitten, you'd be okay. Death likelihood very low. You can see all of these cognitive thoughts, these intelligent sense-making thoughts will start to kick in my prefrontal cortex, and I'll go, it's all right. And I'll send that experience now without the charge. You can see it came to me all red hot, and I send it back green and clear. You're all right. Don't worry. That'll go off into my memory, and I'll have all of these triggers sent to relax. Chill out, keep on walking, alert past, you're all fine. So the all clear response is really important to be thinking about, that comes after that alert response. So let's talk about what I find very helpful to understand that's going on in the context of someone experiencing ongoing traumatic response. So this might be what happens when a critical incident occurs. So a critical incident will come inbound into my brain, and there is some element of this critical incident that I find alarming. And so my brain goes into the alarm response. And what happens in the alarm response is that my prefrontal cortex goes offline, and so I can't do any sense making because I'm in alarm. that's a nasty catch-22, because if I want to make meaning of this thing, I need my prefrontal cortex to be operating really well. And so what can happen, and I put it on there, is that we get caught in this catch-22. And sometimes I will talk to people about it being like the involuntary response that happens if you touch something that's hot. You don't actually leave your finger on there and go, oh, that's kind of pretty warm, I better release my finger, and then you pull your finger off. If it's hot, you will just recoil away. And so this idea that in the brain, there's this kind of intent to engage with the experience because I want to make sense of it. I want to go back to it because I've got this intrigue function that wants to make sense of it, but I can't actually do that because it's so intense in its experience that my alarm system goes off every time I go there. And so this thing gets caught in a catch-22, stuck between my intrigue desire to make sense of it and my alert response that's going on simultaneously. And so I talk about that in terms of that little catch-22. So simultaneously, I'm trying to make sense of it, but I can't. And so I never get that return signal from my prefrontal cortex that says it's green, it's okay, you've made sense of it. Just send it off to long-term memory, and it's something that happened, you won't forget it, but you're not remembering it with all the charge associated with it. So what can happen then? And so if we talk about critical incident response, if you can go to that next slide, please, Susan. Essentially, what we're trying to do, I believe, in the critical incident response work is that we are trying to silence that reaction response. And so you can see there I've put a little symbol next to the return signal that's coming back with the alarm and saying, no, you quieten down, it's all safe, it's okay. And we do this in the context of debriefing or one-on-one counselling or a peer conversation, so that we can spend time making meaning, making sense, putting new categories together, getting some perspective on it, which means that having processed it, that critical incident can now return green and clean, go off to long-term memory, and that will enable our body to trigger the all clear response, and so we can relax. I find it really interesting. So Cliff said the Rob Gordon quote there. I find that really interesting, that if we are to begin to process any experience, we need to reduce the arousal response. And I think that's absolutely clear. And so that's fundamentally what we're trying to do, is diminish the arousal response so that the person can spend time, whatever that means and looks like, and there's 1,000 therapeutic ways we can do that, can spend time making meaning and sense out of the incident, which allows it to come back clean and green, off to long-term memory, trigger the all clear response, and everyone's happy. So that's the theory about what's meant to work. So what does it mean when it doesn't go quite according to plan, which is kind of the next response there, the next slide, if you wouldn't mind. So when it doesn't go to plan, this experience, which I'm calling T1, trauma 1, gets caught in this catch-22 loop, and eventually it finds itself just taking up residence in my lived experience part of the brain, which you can see T1. Sometimes I'll say we try and push it to the back of our minds. You see, it's going right to the back of the mind there, figuratively, I know. But that's a pretty uncomfortable life to be living. You can see that you become angry, tired, irritable, tends to be some of the... But what's going on then is that we now have this experience where we're living in this kind of constant alarm state, and that's a very uncomfortable place to be living. And so you can see down the bottom of the diagram there, what we start to do is we start to treat that incredible discomfort that comes from being on constant alert. And the three big ones, there's all sorts of ways that this is done that I've seen, but the three big ones that most people can relate to, first and foremost, alcohol, to numb that really uncomfortable experience. Second is a whole raft of addictions, some chemical, drug and alcohol, substance abuse, etc., etc. A lot of them behavioural, porn, work, exercise, gambling, all sorts of things that people will turn to dull down that fight-flight response, because it's incredibly difficult to manage life while you've got that response constantly going, or we'll turn to all forms of self-medication. But essentially what we're doing there is, instead of quieting down the arousal in the brain to allow processing time, we're actually just quietening down the symptoms. But the issue is still sitting there in the lived experience part of the brain, but we're managing it by trying to manage the symptoms, and often not in very healthy and helpful ways. And if we do that long enough, which I think is the next slide, we'll end up with the experience of PTSD. So if this goes on for more than a month and the symptoms are severe enough, then we will have a diagnosis of something being really awkward and uncomfortable. And we all know the classic symptoms, hypervigilance, arousal, avoidance behaviours. I mean, avoidance behaviours, really, we'll understand them better when we get to triggering, is that you're just trying to avoid reminders of that experience to avoid the triggering. And again, I find Rob Jordan's quote very powerful here, that PTSD is not so much a disorder of impact, but a disorder of failed recovery. So the idea here is that it's not so much the thing that's happened, but the issue is that the person hasn't properly recovered from the thing that's happened. And so if that doesn't happen, if we don't get that recovery, then we'll end up in this constant loop of this trauma, this unprocessed experience. So I prefer not to think of this as a memory yet, but actually an unprocessed, constant, continuous experience that's in that lived experience part of my brain. I might have pushed it towards the back of my brain. It might not be evident in my conscious all the time, but it's certainly my body knows that it's been going on and it's sitting there. So what does this mean then for cumulative trauma? We'll head in that direction now. So we then have the extra challenge now of not only the traumatic event that first caused and has the charge, sometimes is what it's called, sitting in it, but then we have these trigger events. And so a trigger event is something that in and of itself is not particularly threatening, can be quite innocuous in some ways. And I've spoken to lots and lots of emergency responders who will say this, look, I've dealt with stuff, I've dealt with crap for years, but there's this one thing that happened when I was out and I just can't get it out of my mind. And every time I think about it, it wasn't actually that bad. In fact, it was a job that seemed on the surface to go pretty well. But there was something about that job that I just can't let go. And it seems to, I have this disproportionate response when I think about that job that in and of itself was not particularly difficult. And my theory about what's going on there is that that triggering event in and of itself is not activating the fight-flight response. But the trigger event, a bit like billiard balls on a snooker table, is heading off and interrupting that initial trauma event or releasing some of the charge, not releasing, activating in some way, some of the charge in that original trauma event. And it's the charge in the original trauma event that is then activating the fight, flight, fright response. And so you can start to see now how cumulative trauma can start to assemble, because you're not only dealing with those genuinely traumatic events, those genuine events that you were so alarming and yet so intriguing that you haven't been able to process them, but now you have some trigger events coming in, and they too are unable to be processed, not because in and of themselves they're particularly difficult to manage necessarily, but because every time you try and process them, they get banked up, be caught in behind this process of the original trauma event. So that trigger event itself then becomes another marble or another billiard ball on the table sitting in that lived experience. And now we not only try and avoid memories of the original event, but we even try and avoid memories of the trigger event, because that's too concerning as well, as far as we're concerned. And so now you can start to see, if we go to the next slide, that cumulative trauma then can be a whole assembly of both triggering events and also new trauma events that are unprocessed, that are caught in this catch-22, that are rattling around with one another. Often, people often relate to the idea of marbles in a bag or billiard balls on a table, where if you've got enough of them moving around, they will start knocking each other, and you have this constant stream, potentially, of the fight, flight, fright response through messy combination. And as Susan mentioned, this can happen to anyone. This is a human response. But for those of us involved in first response work, the likelihood of one of these trauma events is higher. And then the likelihood of a triggering event is higher. And then the likelihood of subsequent, and so I use the language there of sequence, which can be a new traumatic event, in other words, a new unprocessed critical incident, or they can be an unprocessed trigger event. And at this stage now, when we're treating this therapeutically, we're having to unpack a bit of a pull apart a bit of a spider's web to try and work through how are we going to support a person that's experiencing this in life. And someone who's experiencing this is going to very likely be, this is incredibly uncomfortable life to be living if you are trying to process all of this or manage all of this on constant stream of fight, flight, fright response. So the use of alcohol addictions and self-medication is often going to be increasing. And part of the difficulty with the cumulative trauma experience is that then those symptom management techniques start to have their own consequences. The gambling that someone's been doing to manage the trauma is starting to have financial and family impact. The alcohol use, which was initially a couple strong drinks before going to bed after each incident, has now become a pattern of behaviour, which is driving some health issues. So all sorts of things, the use of porn, which is now having impact on normal sexual health. The actual symptom management, self-medicating things themselves start to have a cascade of difficulties in a person's life. And so I wouldn't necessarily call them trauma responses. I would call them self-medicating responses to deal with the symptoms of this constant stream of fight, flight, fright that a person is trying to live life with. And so what we're trying to do, I think, in supporting someone in this experience is, well, first of all, let's try and avoid it happening. But secondly, when we're trying to support someone in this experience, we're needing to get back to one or two of those key initial charge events, work our way through the trigger events, work our way through the sequence. And if we can release some of the charge in that initial trigger event or a couple of those, then we'll go a long way towards clearing some of the balls off the billiard table and reducing certainly the fight, flight, fright response to manageable levels potentially. So I think then just a final kind of bullet point. So just in a grab bag of things to look out for, I think, in yourself and others that might be indicators of cumulative trauma. I would say they're the reliving of experiences. And I think a really helpful distinction is that when we've adequately and properly processed a critical incident or a potentially traumatic event, or actually a traumatic event by this stage, then we'll be able to remember it. It's not a matter of forgetting what happened, but we'll be able to remember it without the emotion, without the charge. And so there's a distinction made between reliving a memory and re-experiencing a memory. And so remembering and reliving or re-experiencing. So it's healthy to be able to say, yeah, I can remember, and I think to my own SES experience and turning out to some less than desirable incidents. And I guess some of mine too personally were, I worked technically in a group that we trained up to do confined space rescue, and that sounded really cool when they invited me onto the course. But what they didn't tell me was actually confined space rescue, by the time we got there, normally looked a lot like confined space recovery. And so recovery is never much fun. Doing it in confined spaces is even less fun. And so I've had my own experiences of being up close and personal, and I can tell the difference personally between those incidents that I can remember. I'm never going to forget them, but I'm not reliving them. It's not like I'm back there again. And so that's a really helpful distinction, I think, for yourself and for others. When someone's telling their experience, does it sound like they're back there again, or are they remembering it as if it's clearly happened in the past? There'll be all sorts of avoidance behaviours, understandably, because within the model, we're trying to avoid those triggering experiences that remind us of the charge. There'll be a lot of hypervigilance because we're in that fight flight mode and we can't get out of it. But once we get to cumulative trauma, we'll start to hear stories where people are doing proactive things to numb the symptoms. So there'll be sometimes increased alcohol use, sometimes increased addictive behaviours. So we'll start to hear those kinds of stories too in cumulative trauma that we might not be hearing in initial trauma responses. We'll hear people tell of experiences having minor incidents that seem to have a major impact. They might have a bit of a tendency to make mountains out of molehills and not quite know why they are doing that. Particularly often the common one for me is that I've heard is how they relate to their family, their kids, their partner. Something small goes on and they find themselves having this disproportionate emotional reaction. I think there's some possible signs and symptoms that there might be some underlying cumulative trauma. There might be an absence of processing mechanisms. So people might display signs where they don't seem to have healthy ways and means of talking through things or having good mechanisms for processing incidents and difficulties. Sometimes there'll be an incoherent recount of the incident. So there'll be huge holes in the incident telling of the story. It won't be coming in chronological order. Often what happens when they're telling the story is those incidents and the triggering events and the underlying incidents start to morph into one story. It's a really interesting experience how people can jump back and forth because they're having trouble unpacking the different incidents and they view it often as one. And another thing that I've found just through experience when you talk to people who are experiencing cumulative trauma is you don't hear too much story or evidence in their life of experiences of true relaxation, where they have moments where they're just able to sit at the beach and chill out and kind of let go of life. You go fishing for those kinds of stories and they just don't seem to be there in people's lives. And so that can be a bit of a sign as well that I've discovered. So a model, hopefully it's helpful and useful in your work. I've found it particularly helpful as I've worked with people to help them understand maybe what's going on for them and to understand then the reasons why we might embark upon particular therapeutic approaches. And I guess very importantly then, helping people make the distinction as we respond to, are we going to be doing symptom management in response to their traumatic experience, or are we going to be doing active trauma processing, which is a very different kind of kettle of fish, and both have their pros and cons. So helps me explain to people what we might be doing there. So, wow, thank you for coming along, so many of you. I hope it's been useful and interesting. I'm happy to field any questions that people might have.
There are a couple of questions there, Shannon, but just before we do that, can I ask you to reiterate, you whenever we do our Mental Health Matters program, you talk to people, and I know you've said this in the talk so far, but can you just reiterate your thinking of potential trauma? You know, because we tend to say everything is a traumatic event.
So I would go so far as to say, and putting aside, for those of you who are aware of it, the fact that there is a definition of a traumatic event given in the DSM-5. So putting that to one side for a moment, I think the lived experience and the more useful experience is to say there is no such thing as a traumatic event. I can't look at an event and say that is a traumatic event. I can say it's a potentially a traumatic event, but before it can be truly understood to be a traumatic event for an individual, I have to talk to that individual and find out if it was traumatic for them. Because you can have an incredibly powerful and strong event, and it's amazing how some people just walk away completely unscathed. And I guess when I talk to people about this, particularly from emergency services, and a lot of people can relate to this incident, I can't tell you the number of car accidents I've shown up to. And as you roll and you see the car and you think, this is going to be ugly, and then somehow the driver has stepped out and is standing on the side of the road, and you think, how the hell did you get out of that unscathed? But the reality is they did, you know. So on the surface, this looked ugly, but actually the person physically seems okay. And I think the same can be true for critical incidents or traumatic events. We can look at an event and incorrectly label it traumatic, but we can't know if it's traumatic until we've spoken to the people involved and found out, have they been actually impacted? And the other reason that's important is the flip side. because I too have been to incidents, car accidents in particular, where it doesn't look like there's much damage from the outside, but someone's been hit at the wrong angle, at the wrong, T-boned in the wrong way, and something's happened to their spinal cord, and you think, wow, the damage that was done here seems disproportionate to the incident itself. And so what I've learned, both physically at accidents, but also in supporting people in trauma, is I can't evaluate the level of trauma based on the incident. I have to listen to the experience of the person. And so I get really strong on not describing incidents as traumatic events, because I don't want to assume people are broken because of it. And I also don't want to miss those incidents that might not appear to me to be traumatic in some sort of definition, but there might be some people really struggling as a result. And because it didn't meet my criteria, I'm not attuned and sensitive to what might actually be going on for people.
And just before we move on to questions, can I just ask you to reflect a little bit on this in relation to personal situations? You've talked about, responses in an emergency service role, but, we all have other stuff going on in our life. How do we apply this to that as well?
Well, I think it applies equally in both contexts. So if we think of this as the coming together of two really healthy phenomena in our brain, the phenomenon of intrigue and the phenomenon of threat response, intrigue and threat response can happen equally in my personal life as it can in my professional life. And I think the important thing to think about with threat response, which is one reason why I don't like the DSM-5 definition of a traumatic incident or a traumatic event, is a threat response. My brain can't tell the difference between me being physically scared of a snake and my reputation being under threat, or my identity being under threat, or my security being under threat. I have the same kind of response when there's a threat in some form or other to me or a loved one. And that can come in different forms in your personal life and your professional life. So I think if you think of the idea of this threat response is not just a physical threat response, of course it's that as well, but is actually much broader, and that this can be my response. So if I have an unhelpful conversation in my family, then I might look back on my quite disproportionate reaction to what my wife said there, and I realized that she wasn't physically threatening me, but some of what she was talking about, which is unfair to her, might have made me start to think, oh, I'm feeling like my security's under threat, or I'm feeling like our financial well-being's under threat. And I respond from that fight, flight, threat response, which is not a physical threat, but my brain can't tell the difference between a physical threat and an existential identity threat or a security threat or a financial threat or those kinds of things. It responds the same way. Yeah.
And Shannon, there's a question here from Cliff, which I can relate to very well. 2 times in my life when I've had trauma, I've gone into the skies and I've done skydiving or I've learnt to paraglide. Where does risk-taking behaviour sit as a response to trauma? Is it trying to replace one trauma with another?
I don't think it's trying to replace one trauma with another, but I do think it's a wonderful symptom management strategy. When you're taking high risks, your mind is wonderfully distracted usually. You're focused on something else, which means that you've distracted your mind away from what the thing might be that's keeping it in a space of discomfort and pain. And there are times when, and particularly, I guess, in response to things like grief, which is slightly different, where some level of distraction in a short-term strategy is not a bad thing. So that's not but as a long-term ongoing management mechanism, like all of those alcohol, self-medication, addiction behaviours, they will start to have their own negative consequences. And of course, the negative consequence of risk is twofold. Firstly, if it is risky, eventually then the risks will fall not in your favour. And secondly, to get the same relief, adrenaline relief from that risky behaviour, like any addiction, the level of risk generally has to keep on increasing in order to achieve the same level of distractive response. And so I remember working with a special operations paramedic, and his way of dealing with difficult incidents was to go riding at high speed on his motorbike. And you could start to hear some of his, what was initially just as I'm cruising down the road, I give it a bit of a blast and I go a bit fast and then I'm done, started to become, I go on extended rides at way above the speed limit in order to, and so you can start to see, well, that was, you wouldn't do it if it wasn't helpful. People wouldn't go to grog if it wasn't helpful. People wouldn't go to gambling if it wasn't helpful, temporarily to alleviate the trauma response, but it starts to have consequences of its own that are unhelpful, that start to cascade. So that's a bit of a long answer, but I do understand people taking risk, doing risk-taking behaviour, because it's a wonderful distraction.
Yeah,
and I myself love the odd bungee jump and the odd skydive.
It's jumping out of a plane was certainly a distraction. So there's another question here. Are obvious avoidance patterns in a person a sign of ongoing trauma? What tools are good, helpful for people who are in this cycle?
Yeah, look, I think as far as avoidance patterns are concerned, the question I'm always asking myself and my clients is, are your avoidance patterns life limiting? That's a key question. So is your practice of avoidance meaning that there are things that you would like to do in life, but you're unable to because you're stuck in avoidance patterns? And if the answer to that is yes, then we want to start doing some work. But I can remember there was, and in fact, some of you might know, in South Australia, there's, which is where I'm from initially, as Susan indicated, there's a number of main arterial feed roads heading from the city down south, and I lived in the southern suburbs, and you can pretty much choose from amongst any of them and it will get you home just as fast. Well, there was a season where, after attending an incident, and there's still a cross on the side of the road from the incident that I attended, I would choose not to go down that particular arterial road. When I go in and out of the city, I would choose a different one. That wasn't particularly life limiting. It didn't get in the way of my day-to-day function. And so if I heard my own story there from a client, I would say, well, that's something for us to talk about if you want to. It's an obvious avoidance behavior, but it doesn't seem to be getting in the way of your life. And if you were forced to go past that, how would you be able to cope? And if the person would say, look, I might get a bit teary, and this I'm speaking from firsthand experience, but I don't think I'd fall into a fetal position mess, it would be difficult, but I'd be okay, then I would be okay at that stage with those sorts of avoidance behaviours. But when the avoidance behaviours, whatever they might be, are really limiting in a person's life, they're getting in the way, then I'm going to want to start to lean into them and say, well, what is it that we can do to deal with these? And again, like any trauma, you can deal with the symptom or you can deal with the core issue. And so avoidance patterns of behaviour, you can teach grounding techniques and breathing techniques and all that sort of stuff that enables person to engage in the pattern that would otherwise be they'd seek to avoid. But that's actually not dealing with the trauma. That's just helping them manage the symptom of the triggering event. Sometimes that's enough though. Just like sometimes when you've got a sore leg, a Panadol can be helpful.
Yeah. I'm conscious of the time here.
Yeah.
There's a couple of other questions. I think this one's really interesting from Fabian. What about people that are triggered by having the discussion or being asked if they're okay, but maintain that they would have been absolutely fine if only no one had asked them about it?
Yeah. So very, very real and reasonable question. And what I would say in those contexts is you can ideally avoid conversations if you want to for a period of time, but that's a classic avoidance pattern. But you're not dealing with the issue. It's not like the person has suddenly re-traumatized you or the person has caused you difficulty. All they've done is made you realize that there's an unprocessed event that might be helpful for you to deal with. And so that would be what that would indicate to me, that not that the person who's raised the topic is at fault, but they can do that inconsiderately, but that would be an indicator that there's something more to be processed here. If you're not able to have that distant conversation about the incident that's occurred. And I would say that if you are actually going to treat the trauma, and I'll often use this analogy, I had a sore hip for a long, long time and I had Panadol, but eventually my surgeon said, this hip's got to go. We've got to put a new one in. And let me tell you, it hurt. But I'm glad we did it because it's a whole lot better now. And if we are going to tackle and revisit that traumatic experience, there is going to be some level of discomfort as we do that. And it doesn't matter what mechanism you use, there will be some level of pain. Now, we don't go in to cause the pain, but I think we need to acknowledge that if someone is going to be processing a traumatic event, there will be a level of discomfort, and we need to be able to help them through that and manage that.
Okay, there's 3 questions here and we've got 5 minutes. I'm going to go to this question, re-avoidance. They talk of kids often allowed in the information at the time in their life when they can process it, you know. In an adult, it may be that avoidance, if not life-limiting, allows them to let in that thought memory at a time when cognitively they can process it. What's your comment on that?
My comment would be pretty brief. I would agree with that in the adult context. And I would also say that I think working with kids is a unique specialty that is not my area. And so I wouldn't really have any comment with respect to the child's processing of trauma, but I'd certainly would agree with the assertion relating to the adult's way of doing it. Yeah.
Sarah's asked a very interesting question here. Your point about not being able to evaluate if someone is impacted by an incident raises the question of how stress from exposure can be tracked, monitored and flagged by agencies. And some agencies are starting to track, traumatic events that people are going to. What are your thoughts on this? How can agencies best monitor their personnel for the risk of trauma? Sorry, that puts you on the spot a bit.
Oh, no, that's okay. I guess I had some really interesting experience working with I was the primary mental health support for the Toll aeromedical retrieval team in Canberra. And they go, needless to say, to some pretty interesting incidents. And they had a very complicated system where they were trying to track response in accordance with incident type. And they eventually gave up after much effort, recognizing what I believe to be true, that you can't evaluate that the idea of trying to track according to incident type seems like a good idea at the time, but I think in practice it does 2 things rather unhelpfully. One is that if the incident type is deemed to be particularly serious, we can provide an excessive mental health response when everyone is actually fine. But the other danger at the other end of the spectrum is that something might happen and it doesn't register on whatever filter we put on in terms of our evaluation of what should and shouldn't be a traumatic event. And we miss people who actually need some care because it didn't meet our external definition of what a critical incident might need to be. So I've come to the personal conclusion, and agencies won't like this because it means it's really hard to track this kind of data, but we're dealing with humans. And I think it is interesting to know the number of incidents that a person has attended that might have your classic fatality, line of duty death, children, blah, blah, blah. But that's actually, in my experience, not a true measure of how people are going after the incident.
Okay, there is a question on here about post-traumatic growth, which, if you don't mind, we won't address because I think it's a whole different topic that we might come back to.
But as you know, Susan, it's actually my favourite topic compared to post-traumatic stress disorder.
Well, hold that thought because you're coming back. So but this last question from Chelsea, I think, is interesting. What are your thoughts on the benefits of debriefing potentially critical incidents in a timely manner and at intervals following the incident? Do you think this is helpful, as recent research is showing practices are moving away from debriefing?
Yes, well, I find this a very interesting thing. So debriefing was invented for first responders not people who were the primary victims of an incident and was then intended to be done amongst first response groups. And I think if you look at the research for that particular category of debriefing, including some fantastic research by Michelle Tuckey with volunteer firefighters in South Australia, you will find, and my personal experience is that that kind of debriefing is fantastic, and I'm a huge supporter. Where I have read some research where debriefing hasn't gone well has been, for example, a nurse who came to the bedside of a burns victim and took that individual primary victim through a structured debriefing process, and it was shown to be harmful. And for me, that's like saying we administered chemotherapy to a person with a broken leg, and it seemed to do them a lot of harm and actually no impact on the broken leg. And I'm thinking, well, that's because you applied the wrong treatment to this incident. That doesn't mean that we would stop doing chemotherapy across the board because someone did it badly and inappropriately. And I think if you really pull the lid on the research, what you'll discover is that if you look at groups, if you look at first responders and you look at it done properly, you will actually find that if you break the debriefing research into that category, which is the category that's relevant to us here, you'll find that it's overwhelmingly positive. And I've been to, would be more than dozens, probably getting close to 100 debriefs, if not, and with emergency services responders, and I've found them to be overwhelmingly beneficial.
Thank you, Shannon. I'm going to have to bring it to a close there, but I really appreciate the way you turned this all into some very plain English in terms of how the brain works. And I'm sure there's other people here who had the same response as that paramedic who turned to me and said, why hasn't anybody ever told me this before? I think it's incredibly insightful and really fits ESF's remit about early intervention and prevention, and that is what we're all about. If anybody would like to provide us with some feedback on this, please just pop it in the chat there. We'd love to get it. And yeah, I think we'll be back in the new year with a post-traumatic growth one, Shannon. How about that?
I'm far happier to talk about post-traumatic growth than post-traumatic stress disorder.
Okay, very good. All right, well, thanks, everybody. Enjoy your day, and thank you for joining us this morning and supporting ESF in this way. Thank you very much. Goodbye.
Thanks, Shannon.
Thank
Bye.
you.